Thank you all for joining today. And last week we talked about how to manage small polyps with cold snare. And this week we're going to talk about how to manage a large polyp. And I'm delighted to have Selvi Tirumurthy, one of my colleagues here at MD Anderson, Roy Sitekno, Sylvia Sandlund from Netherlands, and Sriram, who will be joining as panelists. Just bear with me because of time constraints. I couldn't send personal invitation to some of you. So we'll talk about how to manage a large polyp. So these are my acknowledgements, and I'm grateful to my mentor, John Stroline, Mr. Charles Butt for grant support, Angela Deal, medical illustrator, and to my institution for allowing me to do the Zoom classes. So we're going to go over step by step how to manage a large polyp. How do you figure out whether this is benign or malignant when you look at it? And what type of resection are you going to do, whether you're going to lift it or not? And once you resect, what's the role for ablating the edges of the lesion? And what are the benefits of closing a lesion and then putting a tattoo and then sending the specimen to pathology? And what happens to the patient based on what the pathologist tells us? So I'm going to take you through this case, and I would like the panel to discuss some of the concepts. So, so this is actually a 53-year-old man, one of my colleagues from MD Anderson, who came for colon cancer screening, first colonoscopy, no family history, not a smoker, not obese, and he had a very long colon. And I was happy that I didn't see anything until I came to just above the ileocecal valve. This is about a couple of folds above the ileocecal valve, and I see this polyp. So I would like people to look at it. You've seen the lesion, and I want you to take a poll. I will ask Selvi to run the poll. Is this a lesion a pedunculated polyp or a sessile polyp, a laterally spreading tumor of the granular type or non-granular type or a mixed type? All right. Sylvia, what do you think?
In my opinion, without having the endoscope in my hands and being able to get closer, I think it's a sessile polyp. I'm not sure if it is a small peduncle as well. So it could be, according to Paris classification, a PS, not only an S, sessile. So that's, in my opinion, a sessile polyp or pedunculated sessile polyp.
Okay. So one of the things that you want to, I think it's a very good description. One of the things that I suggest when you see a polyp and you are debating whether it is a sessile or pedunculated, you need to ask yourself whether the polyp is in a dependent position or non-dependent position. So you find out by putting in some water and see where the water collects. If the water collects near the polyp is in a dependent position. So sometimes people can make a mistake of thinking a polyp as a large sessile polyp, which in fact was a pedunculated polyp. And I've seen that in my own practice where somebody thought it was a large sessile polyp. And when you rotate the patient and make the lesion become non-dependent, so the polyp actually hangs from the roof. And if there is a pedicle, you will see the pedicle. So that's one thing I want you to keep in mind. And when you have a pedunculated polyp, it's much easier to resect because the pedicle is going to be not difficult to resect compared to resecting a large area of sessile polyp. So something to keep in mind. So what I thought was, this is what I thought, I thought that there is probably the width is more than the height, and there's a lot of sessile components. And as you can see, as Sylvia commented, you wanted to reevaluate the lesion and see if there is a flat component or whatever. So this lesion, I thought, you could go with either a sessile polyp or a mixed type with sessile plus a little bit of a flat component.
Exactly.
All right. So the next step is you saw the lesion, and I want to see what your thoughts are in terms of resection of this lesion. Are you going to use a cold snare, a hot snare without injection, or hot snare with submucosal injection, otherwise known as endoscopic mucosal resection, or you would go with endoscopic submucosal dissection? All right, Shelby, you want to put up the poll? All right. So let's see what Sylvia would do here.
I would definitely opt for injecting, because this will help me to better differentiate between cystile and pedunculated lesion, and it will help me to better resect it. So I would inject a little bit of saline to better visualize the basis of the polyp and to remove it. So EMR would be my choice.
All right. And so I would actually go with EMR. I think cold snare would be very difficult to cut this polyp, but if you want to cut it with a cold snare, there are people who describe this technique. Cyrus from Michigan, Henry Ford, actually described cold snare resection. But when he does that, what he uses is, he uses saline with methylene blue and AP. I think his dilution of AP is, if I remember, is about 1 in 500 AP. And he takes a smaller snare and keeps cutting after injecting the lesion. But you have to be keep in mind that when you have a large polyp with a lot of mass, the snare is going to be, a cold snare is going to be tough when it comes to cutting. So that's something to keep in mind. Hot snare resection without injection is going to cause a lot of deep thermal damage. So that's not probably the safest approach. You could go with endoscopic mucosal resection, or maybe if my Japanese colleagues see this, they would go with endoscopic submucosal dissection.
Raju?
Yeah.
I think, having this course being taught to many, and that we need to stick to the principles of evidence-based medicine, it is important to point out that when we perform resections of pre-malignant or malignant lesion, we should have data for at least 5 years, which is the minimal amount of data for oncological resections. So I think it is not appropriate to use cold snare resection when there is no long-term, large number of patients having been studied. So I think it is, I would argue that it's not the way to go. And I think to make it, to downgrade the resection and make it into something that has a higher risk for residual to come up on the resection side by making it into what I used to call as a corned beef resection, where you cut it into like small pieces, is really, really a bad medicine. It is not very good for the patient because the patient may need more resection in the future, and it becomes harder and harder with the development of scar formation in it. And also for the pathologist, if there was any question whether there is some mucosal growth or not, it would be hard for them when the specimen has been butchered. So I think it is, we should stay away from something that sounds sexy and it can bring you to the front of the podium, and that is called the cold snare resection. So in my mind, it is really the resection that shouldn't be doing. Hot snare resection shouldn't be done here because there is a smaller area between the polyp and the wall. And you would really want to use the EMR technique in order to put cushion so that you don't cause thermal injury to the wall. Endoscopic submucosal dissection, of course, can be done. It might be indicated if there is any potential for malignant transformation. But if there isn't, then it would just create a lot of costs because the type of gadgets that you will need will be a lot more. So there is also cost consideration. So if you distill it down, the most appropriate type of therapy in this is endoscopic mucosal resection.
So Roy, thank you so much. I think it's a very well put. For the sake of the trainees and people in practice, cold snare resection should be limited to small polyps. That's the most important point. And this actually, in this case, as it evolves, you would realize why a cold snare resection would have been a bad choice. And Roy has discussed the reasons why cold snare resection should not be used in a case like this. Of course, you should use cold snare for all small polyps, and that's part of our guidelines as well. All right, thank you, Roy. Okay. So in terms of, once you decide that you're going to do endoscopic mucosal resection, what solution would you like to use? Would you like to use Saline, Hetastarch, Orise, Eleview, or Hyaluronic acid? All right. So it's interesting that half of the group are using preferring Saline, and the next is Eleview, followed by Orise and Hetastarch, a small proportion hyaluronic acid. The thing is, in terms of submucosal injection solution, the choice, which one you want to go, Saline works for the most part, except that Saline could get reabsorbed much faster. So that's what people have. People felt that, okay, how do you give a sustained elevation? And maybe less injections and more cuts by using a viscous solution. Hyaluronic acid is very costly, not available in this country, at least in the US. So the other options are either Hetastarch, Orise, or Eleview. I prefer to use saline, but when you use saline, you want to make sure that you have everything set up right. The patient's electrosurgery, the connection to the electrosurgery unit is set up. You have picked up the snare that you want, and as soon as you inject saline, once you're happy with the elevation, you should not waste any time. You should be ready with your snare to cut. If you follow that principle, saline does work. It is probably much cheaper than any other solution. So my preference is saline with either a little bit of methylene blue or indigo carmine and a little bit of AP in a dilution of either. You can go 1 in 100,000 to 200 or 500,000. So let's, I want to take you through this injection. What I've done is these videos are, once the needle comes out, until the injection is done, I try to minimize the amount of editing. So you probably see the entire injection. So the key is, as you can see, there's a cap at the end of the scope. I went forwards to the cecal side of the lesion, and I flushed the needle, make sure that the needle is primed. That is one of the things you want to do. And then start injecting. As you can see, we injected a little bit. My assistants have perfected this art of injection by just tap on the plunger. By doing that, you allow only a small aliquot of fluid to come out, and then make sure that you find the submucosal plane. Here, in this injection, we had a little bit of a mucosal bleb, and then we plunged a little bit deeper to get into the submucosal plane. So as you can see here, each injection is typically about a large amount of fluid that we injected, about 10 cc's. And if you have a polyp on a fold and it goes on either side of the fold, as this polyp has done, this polyp is at very high risk for perforation. And if you look at the literature and ask yourself which polyp is at high risk for perforation, one of the features is a polyp going on either side of the fold. So as you can see here, we are taking time to inject and lift the lesion away from the fold. That is a little bit of a mucosal bleb, and then you want to go a little bit deeper to get into the submucosal plane. So I'm injecting on the top of the fold after having injected fluid on either side of the fold. And this is the last injection, again, trying to get a good lift above the fold. So you may be wondering how much of fluid did we inject? In this case, we injected about 33 ml of fluid. This is saline, and that has given a nice lift. And you can see that the most of the surface looks do not show any features of overt cancer in this video. So something to keep in mind. The most important thing from an assistant point of view is to learn to do two things. One is inject a small aliquot of fluid by tapping on the plunger. And the second one is the assistant should stop injecting when he or she creates a mucosal bleb. That means the bleb is in the mucosa, but not in the submucosa. You want the bleb to be in the submucosa to get a good lift and have the benefits of a submucosal injection. The other one is something that I've learned from Roy, is the so-called dynamic injection technique. As you inject, you move your fluid needle in different directions to jet the fluid so as to bring the polyp to a suitable position for your resection. Roy, any comments?
I think it's great. I think the other part of the injection that Raju has done, but may not have told us, is that he wanted to inject so that the polyp is facing towards the endoscope. So there was more injection by design on the proximal side on the of the lesion. That way, then the lesion is not flopping away from the endoscope. So now the lesion is facing the right way and is ready for resection.
Yeah. I would like to, thank you, Roy. I would like to make, Sylvia, you want to make a comment?
Yes, if possible.
Please.
I think the submucosal injection helped us to better characterize the macroscopic aspect of this lesion. So a part of the participants thought it's a pedunculated lesion in the very beginning, but now after the submucosal injection, we don't see any pedicle, so this is not a pedunculated. And the other option was, if I recall well, was laterally spreading tumor. And for a few seconds, I was thinking, well, it might be a lateral spreading tumor of granular type, but it's still not the height and the width are almost similar. So I would still say this is a sessile polyp.
That's good. Thank you. Thanks for those comments and feedback. I think it's good to discuss so that everybody learns better. So the other thing that I would like to make a comment for everybody to keep in mind, as you can see here, the scope has a cap. And the cap is about 2 to 3 millimeters beyond the tip. And this was a screening colonoscopy. Our group actually, majority of our colleagues in our group have started using cap routinely. And if I did not have the cap, I would be struggling with this resection. Especially this was a screening colonoscopy in a 50-year-old. You don't expect a large polyp in a 50-year-old. The percentage of patients with large polyps in a 50-year-old is probably very small. So when you wanted to resect this lesion, you would be struggling if you didn't have a cap. So it's a good idea to start your scope with a cap as a matter of a routine, if possible. So how are you going to resect this lesion? Are you going to use a forced coagulation, a soft coagulation, Endocut Q 315, Endocut I 315?
We need Salvi.
Hmm?
We need the pole.
Yeah, she's actually doing that. All right. Roy, you want to comment on that? Okay, what it shows is 87% picked up Endocut Q, forced coagulation 7%, soft coagulation 7%, Endocut I 0%. Endocut I basically is used for needle knife or a sphincterotome, so that's not the right answer. Soft coagulation, soft coagulation cannot cut, it only coagulates. The voltage is less than 300 volts, right? So with that current setting, you don't cut. So it is used basically for hemostasis and ablation of the edge with a snare tip. So you have a choice between Endocut Q or forced coagulation. And the recent paper that came out in Gastro basically showed that there was not much of a difference between the two. Roy, you want to comment on that?
I think the purpose of this is to cut, right? So I think it's interesting that we still think that we can use coagulation. What we want is we want to cut. We don't really want to coag. So the answer is really Endocut Q. If you use more coax, then you basically are going to cook more towards the wall. Of course, in this case, there'll be little effect, but because of the submucosal injection, but really appropriately, this is a cutting job, and you use the right tool for the job, and you use an endocut.
Right. Okay, that's good. So this is what we did. I'm going to show you the video from start to the beginning. We picked a large snare. I thought that I'll be able to, I had a lot of injection. I thought that I'll be able to cut en bloc. So we picked a 25 millimeter stiff snare. For those of you, if you are interested in the make of the snare, this was made by Olympus. And I want you to know that I have no conflicts with Olympus. Just for the sake of information, I'm providing that. As you can see here, because I had a better scope control, I was able to get my snare around the polyp, and I thought that I was able to do this thing as en bloc resection. So once we were able to get it around, we used the 315 cut, and as you can see, it is slowly cutting. And one of the things you have to keep in mind is when you have a large polyp resection like this, you should be worried about possible bleeding. And fortunately, there was no bleeding. And for the most part, we probably cut 90% of the polyp in one go, and there's a little bit at the edge. And we were able to cut that as well. And the submucosa looks clean. So when you cut and you see nice blue fluffy area, you know that the resection depth is limited to the submucosa. If you see white bands of muscle bands, then you know that you've gone a little bit deeper. And when the resection goes to the muscle, that patient is at risk for delayed perforation. So something to keep in mind. So any comments on that, Roy?
I think there is a subtlety that we need to inform the audience, which is what Raju had done is that he had put the snare first on the side that's closest to the endoscope, and then close the snare from the side that is far away from the endoscope. And what that does actually, when he closes, what that does is that it kind of like pull the lesion towards the endoscope. So it is important that when you close the snare, that there is, you're really kind of like pulling it away from the muscle layer. I don't know, I couldn't discern whether he had done this step whereby the assistant opens the snare slightly and the tip of the snare is lifted up slightly and then closes. And at that time, I think Raju and his assistant were also asking, are you having too much tissue? Are you having about the right amount of tissue, and so on? These steps are important so that the resection does not include the resection of the muscular dystrophy. There is like a subtlety to the snare placement, to the last step before you apply the cautery, and to the checking with the technician to ensure that the amount of tissue that's being captured is appropriate.
So Roy, I'm blessed with the best technicians in the country. So yeah, I think one thing is very important is as endoscopists, we should have a lot of patience in educating our team so that over a period of time, both the assistant and the endoscopist work in sync. And it's worth taking the time to educate everybody so that we don't have to instruct every single step as we do the procedure. So how do we prevent any recurrence? Do we cut more and take off normal tissue? Do we use a snare tip or soft coagulation of the edge? Or is there any role for APC of the edge? All right. Sylvia, you want to talk about it?
I think that I will carefully inspect the margins to make sure whether there is residual tissue. And I would not always apply APC or soft coagulation blindly. But if there is some uncertainty, we apply indeed APC in the Netherlands. So just in case when I'm not sure there is residual adenoma. For the rest, if there is some tissue, residual tissue, which still can be injected and resected, I would prefer to resect it instead of applying the APC.
Sriram, any comments?
I agree with Sylvia. I would like to check if I got the margin or not, and with NBI, and if I have any suspicion, then I use soft coag for the margins.
I definitely agree. Yes, only in case of suspicion.
All right. So what I would like to do is I would like to share with you when I started at Anderson in 2009. I said to myself, every large polyp resection, I would do APC of the edge as part of the routine and see what happens to the recurrence rate, So this is part of a protocol that I followed. I use forced APC with a forward jet APC catheter and set at 35 watts. The only time I increase the wattage to 50 is if I'm resecting a polyp that's been tethered from prior resections and I'm not able to, and I want to make sure that I get a deep thermal injury in those cases. Otherwise, 35 watts forced coagulation, 0.8 liters of flow. Before I do this, I routinely take pictures of the edge of the lesion to make sure there is no macroscopically visible tumor. So if there is any visible tumor, I either use a snare or a hot biopsy or a cold biopsy to remove any visible tissue and then apply APC. When we looked at our data of close to about 250 plus patients, something like that, large polyps, more than 20 millimeters, our recurrence rate was about 3 to 4%. Most of the recurrence was actually in patients that were previously resected and came back, or resected and was incomplete resection. But if you have a clean large polyp, 20 millimeters plus 20 to 25 millimeters, the recurrence rate is almost close to zero. If you follow the protocol and say, I want to have a clean edge, nothing in the base, and apply the APC, it's almost close to zero.
Great.
So what do we do? All right, shall we want to put the poll? this lesion is at risk for bleeding. Is it at risk for bleeding? And are the clips beneficial or not? So do you close the defect with clips or do you leave the defect open? All right. Sriram, what would you do?
I would, before I close the case, before I get out of there, I would like to examine it for any visible vessels. And if I can identify, I'll use a soft coag to take care of it and leave it open. And my rationale is this. If I don't see a vessel and then which I can take care of now, and if this patient were to develop a post-polypectomy bleeding, that will be from a vessel that I do not see. And if I close it off with a zipper, subsequently it might be difficult for me to manage that bleeding. Whereas if I do see it, if I don't close it, I can come back and do the appropriate treatment and if necessary, put clips at that time.
Okay. I want to hear what Roy would do and Sylvia would do. And how about Sylvia? Yeah.
I would close it and be done with it.
I think that I would close it too. It's a large lesion, although as far as I remember, the patient doesn't use anticoagulant therapy or things like that, but it's still a large lesion, so I would prefer to close it.
I think it's right side and it's large. And the other factor is that if the patient is on aspirin or anything like that, and if the patient comes from far away, I think what Raju will also tell you is that he will say, well, we will make sure that all of the surfaces does not show any deeper cut, which in this case there is none. But other than this, then you would close. What I meant with the deeper cut is that if there is any evidence of a deeper cut at any part of the resection, then you will focus on that area with making sure that the closure is complete.
Sylvia, what do you do?
Yes, sir. Yes, I agree. I agree with Sylvia and Roy. It's a large lesion on the right side. I would close it.
Okay. So for the sake of our trainees and colleagues, there was a lot of debate about whether we should close the defects or not. And there is a randomized trial now that came out in gastroenterology where they've shown that if you close the defects, especially in the right side, especially if they're large, or if they are also an anticoagulants, the benefits, there is a lot of benefit to closure. There is a study from actually Spain where they talk about closure in a little more detail. What they looked at it is, do you close with clips and leave some gaps in between? Or do you close completely, like partial closure versus complete closure? And compared to partial closure, complete closure has a lot more benefit in preventing delayed bleeding. So the data does show that. And there's also another study when they looked at Medicare payments for clip closure. And they felt that if you close a defect on the right side for a large lesion, the Medicare would save almost $500 for each case compared to not closing it. Because when the patient comes back to the hospital, goes into the ICU, transfusions, another procedure, when they put all the costs together, that cost is a lot more. So because of those reasons, I think now it makes sense to close. It's also very interesting when I was in UTMB, I did a lot of animal work on closing perforations. And when we looked at the colons of pigs after closing perforations, I could see the clip actually go almost full thickness closure. And because of that, when I came to Anderson, I was closing all my defects for the last 10 years. And Heiko Pohl, who did the study, invited me to be part of the study. And I felt that, based on my own data, the rebleeding rate was very low. It's about 3 to 4% when you looked at your own data. And I did not enter into that study because I felt that clip closure made a big difference. And my own data showed that 3 to 4% compared to the literature talking about 10, 15, 20% delayed bleeding rate. And interestingly, Heiko Pohl shared with me this information. He said, Raju, when we did the randomized control study, and when I was looking at the results, I was completely blinded. I was expecting that this study will be a negative study. What he meant was that clips will not be beneficial, or clip closure will not be beneficial. And he was totally surprised. So something to share about the clips and the closure and bleeding. All right. So I want to share with you some of the stuff that in terms of how do you close a defect. So it's a good idea to close the defect. Probably put the first clip at the edge so that you evert the edges, and that makes it a little bit easier. And when you have a large defect like this, probably it makes sense to use a clip with a wider opening. And this is a clip that can open up to 16 millimeters. So we started with that. But one of the disadvantages of this 16 millimeter clip, I think it is made by Microtech, is rotation is not necessarily 1-to-1. So I use this clip to close a large defect. And then I try to use clips where I can have much better control in rotating and closing the defect. Like here, if you see this from an engineering perspective, the resolution clip, whoever designed it, the rotation is 1-to-1. It's probably much better. But the wingspan of this clip is shorter than the Microtech. So you have to keep in mind what really works. The other thing is, by having a cap, I'm actually pushing the clips below to allow myself get into a better position to close the defect. And here, as I'm closing, I see a couple of blood vessels that I did not see earlier. And I used the principle of what Sriram talked about, look at the blood vessels and do soft coagulation or whatever. So it's very interesting. You will see that I'll be futzing here for a long time to do the soft coagulation. And what happened was my machine was set at APC because we used APC before. And it was a little bit of a struggle to change from APC to soft coagulation. So the reason why I want to make this point is that anybody using electrosurgery should be able to quickly change the settings. As you can see here, by this time we should have actually soft coagulated and moved on with our clipping. So here I'm holding onto the forceps while my assistant is trying to change from APC to soft coagulation. So in the process, we have to shut the machine down, restart the machine, and it does take time. So when it comes to soft coagulation, we use anywhere between 50 to 80 watts, soft coagulation, effect 4, and that would nicely coagulate vessels. So this soft coagulation forceps, it's a coag grasper forceps that come in different shapes and sizes. This is the one for colon, which has a smaller blades. So the other thing you have to keep in mind is, if you look back, this is a patient who came for screening colonoscopy, and we found this large polyp. We felt that it is a good idea to take it out, but you have to keep in mind that when you start attempting this thing at the beginning of your day, this happened in the beginning of the day, you would run late, and then your patients that are waiting for you may get a little bit upset. So something to keep in mind, you know. If you schedule your colonoscopies for 30 minutes or 20 minutes, depending upon your practice, suddenly doing this large polyp resection would take a longer time. It took almost an hour for us to do this whole resection and complete the examination. And it's also important, if you're doing resections like this, to reach out to the family and say, we found a large polyp, we're going to resect it and take care of it, so that people know what is happening. Because the risks of screening colonoscopy are different from the risks associated with a large polyp resection. So we actually used 10 clips to close the defect, and it's a good idea to mark the site. I usually use the spot or whatever and inject into the submucosal blood, and inject a little bit, not too much to make those clips loosen. And finally, when you're retrieving it, one of the things that you have to keep in mind is when you use a net and bring the polyp out, make sure that your net doesn't catch the clips. So you want to distend the colon and make sure that the net doesn't catch the clip. So this is the pathology. All right, Elvie, you want to talk about that?
Okay, Raju. So the pathology shows that there is adenocarcinoma that is, so you see these glands that are fused together and they're crowded. And do you have another picture, Raju, or is this the only one?
Yeah, there's another one, sorry.
This is the only one. So no problem. So
okay, this is
this one, yes. So can you show the muscularis mucosa layer? There it is, the pink layer. And you can see that these glands have actually pushed through the muscularis propria layer and are below that.
mucosa.
Yeah.
So this is this pathology is very interesting. I'm going to go to the next slide. Okay, that's the gland that has penetrated the muscularis mucosa, and this is a copy of the pathology report. So want to read this thing out for you. There's a diminutive focus of invasive, moderately differentiated adenocarcinoma of about 0.5 millimeters, extending into the superficial submucosa, arising in a tubular villus adenoma with patchy high-grade dysplasia/intramucosal cancer. No high levels of tumor budding identified, no lymphovascular or perineural invasion identified. Completely excised, invasive adenocarcinoma is 0.1 centimeter from the deep margin of resection, reviewed by at least 2 pathologists, and we actually reviewed it as part of our weekly pathology conference. And they also went ahead and did the immunohistochemistry, looking for mismatch repair enzymes, MLH1, MSH2, MSH6, and PMS2. And the staining was intact in cancer cells and non-neoplastic cells. And they reported as microsatellite instability is low. And that's what they talk about. So Roy and Sylvia, do you want to comment on the path? And
I think the invasion is indeed very superficial. If anything, it's really at the bottom of or the deeper side of the muscularis mucosa. I would just want to make sure that that they have done special staining to make sure that there is no lymphatic involvement. That one gland that you showed us, initially I was saying, well, is this inside a lymphatic or not? But I trusted that all of you have refuted and then decided that it's not inside a lymphatics. Um, I think I would tell that to the patient that look, this is the situation that we have. And we have published a meta-analysis on this very subject, and the risk, according to the Japanese, is 0, but that does not include the 95% confidence interval. So if you include the 95% confidence interval, because the number of cases is relatively low, there is some risk that's more than 0. I think the risk is about 2% or so. And that could be important. I mean, a 50-year-old may say, I want a 0 risk. And if the risk of laparoscopic partial colectomy is 1%, for example, he might say, well, I really wanted to take a lower risk. So this is the importance of including patient preferences into the decision. But honestly, if I have something like this, I would say the risk is really, really not towards the outer limit of confidence interval, but it's actually much more inside it, and it's very, very low. It's probably very much 0.
So Sylvia, what do you do differently? Anything different?
No, I just want to make a comment. Getting back to the macroscopic assessment, I was worried actually about the proximal part of the lesion, which could not be well visualized in the beginning. So maybe the focus of submucosal invasion was there. I'm not sure. But anyway, this underscores the importance of taking decision based on macroscopic assessment, because if it was a lateral spreading tumor of granular type, we could remove it by piecemeal resection in many pieces. But that could be wrong, could be actually unfavorable in this case. So it was good to do en bloc resection, even if the small margins were later removed, but the biggest part was removed en bloc. So I think that was the best decision, because a sessile polyp, unlike the lateral spreading of granular type, which has a risk of submucosal invasion less than 1%, the sessile has a risk of up to 40%. So we should try to resect them as much as possible en bloc.
I think this pathology also highlights why doing a piecemeal cold snare resection would be
exactly
not really, right.
Yes.
Right.
Yes.
Yeah. The other thing is, for the sake of the trainees, I want to highlight, I've highlighted here several important points. Moderately differentiated, superficial submucosa, no tumor budding, no lymphovascular invasion, no perineural invasion, and deep margin is at least 10 millimeters free. All those things are favorable features. If the patient had a poorly differentiated, it doesn't matter if the margin is free and everything else is clear, the patient would have gone to surgery. If the patient had multiple tumor budding, again, they would have gone to surgery. If they had a lymphovascular invasion or perineural invasion by doing some special stains, they would have gone to surgery. And finally, the margin, right? Margin in somebody less than 10 millimeters, again, they would have gone to surgery. And it's a good idea when you see a case like this to get a couple of pathologists to look at it and make sure that they both agree and get the best opinion for the patient. And for every cancer, we should always get the results on the mismatch repair enzyme status or microsatellite instability status. Selvi, you want to comment on that?
Sure, Raju. So some centers only do testing for Lynch syndrome, which is what these tests are. If the patient has young onset colon cancer, other programs may actually do universal testing of colon tumors for Lynch syndrome. Technically, we're supposed to do it at our institution for every colon tumor, colon cancer that comes through pathology, but sometimes we need to, fill out some extra forms to do the biomarkers testing on these tumors. But I think it's important, definitely keep it in mind for patients with young onset colon cancer. This patient was only 50. And if it require, I would talk to your pathologist. And if you don't see these, this little alphabet soup at the bottom of your pathology report, whenever you get a colon adenocarcinoma, I would check with your pathologist at your institution and see what the process and protocol is. And maybe they need the clinician to put in the orders for the special testing.
Thank you. So the patient, after this thing, we got a CT, chest, abdomen, pelvis. It was negative for metastatic disease. His CA was 5.2. Normal is 3.8. He went and saw a surgeon, and the surgeon gave the numbers, and he wanted to follow surveillance. So let me take this one actually. Let's do this poll also. What would you do actually if this is your patient? Would you send them straight to right hemicolectomy, or if the patient says no, I want no surgery, just follow up? Would you agree with that, or you push him and say right hemicolectomy? All right. Okay, I think it's good to see that everybody agreed on just follow up.
Right.
So after the first procedure, I want to take you through this diagram especially for the sake of fellows here. You have mucosa, submucosa, muscularis propria, and serosa, right? So mucosa has epithelium, lamina propria, and the mucosa mucosa is separated from submucosa by muscularis mucosa. So I want to help people understand dysplasia to cancer. So dysplasia, low grade or high grade, is limited to epithelium. And when it goes into the lamina propria and touches the muscularis mucosa, that is intramucosal cancer. And when it goes through the muscularis mucosa, then it becomes invasive cancer. And invasive cancer could be limited to upper 1/3, go down to the middle 1/3, or lower 1/3. And then it becomes a T2 cancer when it touches the muscle. So as you can see here, I'm just repeating it again because these are things that are important for you to keep the concepts. Dysplasia or abnormal cells that are limited to the epithelium is non-invasive. It is a non-invasive cancer. When it goes into the lamina propria, it is intramucosal cancer. And then when it goes through the muscularis mucosa, it is invasive cancer. So these are the concepts you want to keep in mind, okay? So unlike esophagus, unlike stomach, in the colon, there are no lymphatics in the mucosa, and the lymphatics in the upper 1/3 of the submucosa are very, very sparse. So when you go ahead. So when you look at submucosal cancer limited to the upper 1/3, and when they looked at the lymph nodes, like Roy suggested, commented on, the lymph node invasion is less than 1%. And this is the data, a lot of this data came from the Japanese. And when it goes into the middle part of the submucosa, the risk of lymph node invasion increases, and it goes into the deeper portion of the submucosa, it goes to almost about 14%. So the reason why we felt that it's a well-differentiated cancer, limited to the upper 1/3, chances of lymph node invasion is small or almost close to 0. So we decided that surveillance is not a bad option that the patient took. So this is 6 months later. This is the EMR scar. And this is not recurrence of polyp. Sometimes what happens is when you put a clip here and here, in between those clips, the tissue tries to bridge. And these are what are called pseudopolyps. And when you see this, make sure that you examine under white light, NBI, and everything. And then you take a lot of biopsies. And you can pretty much tell whether that nodule is a granulation tissue or residual adenoma. So we took a lot of biopsies. The biopsies show erosion/ulcer, no residual adenoma or cancer. And then 12 months, this was actually done just a few days back. As you can see here, that's the tattoo. And then you have a clean scar. And again, we biopsied, and the biopsies show no dysplasia, nothing except some granulation tissue. So at 12 months, we repeated the CT, and the CT was again negative. But one thing that is happening is he is having slightly borderline elevation of CEA, and we are trying to get a second opinion from one of the oncologists. And I put this figure again. This is the muscularis mucosa, and you see the gland just in the superficial submucosa, and that's what it belongs to, where in the presence of a well-differentiated cancer, no perineural, no vascular invasion, their lymph node involvement is very, very low. So thank you. We'll just open it for any questions, and then we can wrap it up. I really appreciate you all joining us. Sylvia, any other questions there we have?
No.
Okay.
That's a very clear case.
All right. Roy, any comments? Sylvia, any comments? Sriram?
No.
No,
Very
we are
clear.
good.
All right. If there are no other comments, we'll wrap it up. And I want to thank you all for joining. It is, and I want to thank Selvi for helping us record the path. We're able to include some path in the meeting so that we can learn a little bit better. Thanks again.
Thanks, Raju.
Bye-bye.
Thank you.
Thanks, everyone. Bye-bye.
Thanks a lot. All the best.
Thank you, Sylvia.